Welcome to the Beyond Physio Podcast, where we help you move, excel, and inspire others on your journey to your next level with knowledge and advice from experts and testimonials from our like-minded community.
Welcome to the Beyond Physio Podcast. I'm Dr. David Kwon. I'm joined today by Dr. Scott Hanauer. I pronounced it correctly, I think.
You did.
He is a local podiatrist and one that we are continually developing a relationship with. Would you be able to introduce yourself?
Yeah, absolutely. So I actually grew up here in Jersey, in Livingston, and made my way from a local high school athlete to going over to University of Maryland, where I started out actually as a biology major, transitioning to a kinesiology major on a pre-med track. And fun fact is I did play for the women's basketball practice squad.
Nice.
At Maryland, which is pretty awesome. It's my only fun fact, pretty much. And from there, I actually came back to New York for podiatry school. I went to New York College of Podiatric Medicine, where I did all my basic training, eventually heading back to Northern Virginia, right outside the DC area, for my residency training, which was focused in reconstructive foot and ankle surgery and sports medicine and minimally invasive surgery. And following completion of residency, came back to Jersey to practice, and now I'm over at Garden State Pain Orthopedics, living the dream.
Awesome.
Loving it. Yeah. Still living in Manhattan, though.
Oh, you're commuting back.
Yeah. So
Gotcha.
yeah, doing the reverse commute.
Gotcha.
My wife and I are still enjoying the city while we can.
That's fun. So another fun fact, Dr. Scott possibly had aspirations possibly of being a physical therapist back in the day, and then kind of shifted your focus, and you actually developed an app. Is that
yeah.
so?
So, going back to freshman year of college, when started pre-med, started on the biology major, and I got through the first semester and, had a moment where I looked in the mirror and said, do I want to do this? Do I really enjoy the classes I'm taking? And question whether I, want to be the doctor just because I thought that's always what I wanted to do, and question if that was really, did I explore the other medical fields enough? So with that, I switched majors to kinesiology, still staying on a pre-med track just in case, and started shadowing physical therapists. I even shadowed a chiropractor, and also was shadowing the team orthopedic surgeon, trying to get a taste of all aspects of medicine, which definitely helped guide me towards the career path that I ended up landing on, which is podiatry. But yeah, in college, my brother-in-law and I worked on an app called Rehab TheraX, which is a application for your phone or for the iPad that allows physical therapists to come up with rehab programs specific to patients that you can email directly to the patient. So great for a lot of home therapists, or physical therapists not associated with any hospital system or practice, where they're on the go and they need to give their patient a program directly. So
awesome. Rehab TheraX.
TheraX, yep.
Awesome. That's
Yeah.
cool.
So it's great. It's definitely, I think without the hours I spent shadowing physical therapists, I think that definitely helped guide me towards what I wanted to do, and also gave me a better understanding of what physical therapy does for patients and the importance it plays in the recovery process from the time of injury to potentially post-operatively and so forth.
So like you're alluding to, how has that experience kind of changed your perspective of what physical therapy is and its importance in the continuum of care and your relationship with rehab professionals?
Yeah, definitely. I think that it's interesting when I started off shadowing orthopedic surgeon, and, and at that time, you're blown away by the idea of doing the surgery or big ACL reconstruction, and you see that patient post-operatively a few weeks later. And the doctor at that point takes the stitches out, everything's great, and they say, all right, I'm going to send you to therapy, and you'll work with therapy, and I'll see you back in 4 weeks. And they just miraculously show up 4 weeks later, and the improvement from that time, you didn't see any of it. It's just you're expecting that the patient's going to walk in and you're going to have a huge improvement in the patient's pain and the range of motion. And it's just a kind of an expectation, right? They just show up and they're great. At least most of the time they're great. And I think having that time in working with physical therapy in college really helped show me how much effort and how much work, not just from the patient, but really from the therapist to work with the patient and develop a patient-specific treatment plan, and how important that is in that recovery process, and how every patient is different. Some are easier to work with, some are more difficult, but in doing so, you're coming up with a specific plan based on the patient's age, their weight, their activity level, and no matter what, getting them towards that same outcome, which I think is impressive. I think that, most surgeons, especially in the orthopedic world, are, very appreciative of what goes into the patient care from the therapist to get them to that point. Because surgery is only half the job. Yeah. Therapy that goes into it after it is questionably more important.
Yeah, I mean, that's super refreshing to hear. Like, as far as my career, I don't get to go to that post-op meeting with the ortho every time. I have been. I've gone to some of the post-op appointments with the patients, but it's kind of refreshing to hear a doctor and a surgeon understanding the hard work that goes into the treatment plan and really the care and attention that goes into completing a successful plan of care. And I think that also kind of leads to my next question is your approach to medicine different than maybe some other doctors might be, or your approach towards surgery different than some other doctors might have, based on your experience and based on your understanding of anatomy and kinesiology?
Yeah, definitely. I think that, medicine nowadays is going more towards a minimalist approach in terms of maximizing conservative care. So, for any patient, whether they're coming in for some type of sport-related injury or arthritic pain, whatever that may be, no matter what, we're considering our conservative treatment measures first. I think that I've had patients who come in with injuries where in the back of my mind, I'm thinking, yeah, they're probably going to end up needing a surgery for this. I mean, and you'd be surprised on how many of those patients come back 6 to 8 weeks later and they say, I feel great. They're stable, they've got their strength, and they've proven me wrong. So I think that's definitely come a long way for me, where I say, let's give it a shot. It definitely works for many patients. And for those where it doesn't work, let's talk about some of our surgical options, some of which might be less invasive, cause less scarring, and might allow us to rehab you faster and quicker and more aggressively. So I think that's, at least from my role as a foot and ankle surgeon, that we're going down this path of trying to do open less, smaller incisions, more robust fixation, which allows for us to be more aggressive in getting patients to therapy right away. You don't see us casting patients as often. In my time out of training, I don't think I've really put on a single cast. We're trying to get patients moving as fast as possible after surgery to avoid the stiffness and pain that comes following some of these surgeries.
Yeah, I mean, I think that the understanding of, at least each profession has their limitations, right? Like, I've had patients where I thought I could get them better, but they didn't. And I had to refer them to a surgeon or an ortho because they needed surgery, right? It's interesting that you also pointed to the fact that, there are some patients that you potentially thought needed surgery and then ended up not needing surgery. And I think that a lot of patients are looking for the ability to check off a lot of the boxes before they end up having surgery, and an understanding that it is a big commitment. However, the techniques that you're using sound like you're going to do the least amount of damage possible in order to get the best possible outcome. Absolutely.
And I think that when it comes to talking about especially elective surgery and foot and ankle surgery, that it should really be a team decision. I think we've all been there when you show up in a doctor's office and you have all these questions in your head and you're thinking about everything. And then all of a sudden the doctor walks in the room and you kind of go blank. You kind of just forget everything you wanted to ask. And next thing you know, you're being told that you might need a surgery and you're just kind of nodding your head. and you go home and you're like, I think I'm scheduled for surgery in the next, and that it happens. And I think that the way of avoiding that is really making sure that the treatment plan is a team approach between the surgeon, the patient's therapist, and the patient themselves. Of course, it needs to come to that decision on their own, where they know that, like you said, they've checked off the boxes. They've tried their conservative therapy. They've tried physical therapy. They've tried injections, and they are still dealing with pain daily. And that's when I tell them, hey, if your body is telling you that something hurts every day, every step you take, you're thinking about some part on your foot, that's not normal. And that's when it's time to do something about it and take action.
Yeah, I mean, I think that the whole concept of a goal-oriented approach where we take into consideration the patient's goal. Like, for example, we have a patient who has been having some foot issues. Her goal was to complete the Boston Marathon. And she had struggled with alcoholism, and she had struggled with a lot of other issues. And running is the thing that like saved her life, right? So we as physical therapists, as a team that's treating her, she running to her is not a matter of like leisure. It's a matter of life and death, right? Like to her, her goal is that she has to run. So some other approaches, some other people might say, just stop running if your foot hurts. Where the mentality and the change in terms of our approach might be, let's do as much running as we can while maintaining and protecting the joint. And it sounds like you have a very goal-oriented approach as well, where you take into consideration what the patient's goals are, and like, do they want to play pickleball? Are they just looking to walk around the city? Do they want to get back to playing football? And the importance of that in terms of the whole continuum of care between physical therapy and orthopedics.
Yeah, definitely. And I think that using your patient as an example, you tell a patient like that, hey, there's a surgery that we could do that might fix this, but it might put you out 3 or 4 months. And you're going to miss that marathon that you've been training for. That's not always an option in patients' minds. And I think that, going back to what you said, if it's a team approach where everyone's on the same page, the therapist, the surgeon, the patient, then, and you have the same goals in mind, then you can work towards those goals together. Where working on rehabbing the tendon or getting the patient in a good pair of orthotics or a good pair of shoes or something that we could do to at least get the patient more comfortable so that they could reach their goals, then that's successful treatment.
Yeah, that's amazing. So I guess we could kind of talk about some specific questions that we might have for a podiatrist.
Sure.
One question is, in terms of athletes, what are 3 of the top injuries that you see that usually require some sort of intervention from you and may or may not improve with necessarily physical therapy or other conservative care? Sure.
I'd say, most commonly in my practice, I've been seeing a lot of ankle sprains and ankle instability, whether that be acute, where it just happened, or in a more chronic setting where someone who was an athlete who's sprained their ankle multiple times throughout their career, they've just recently sprained again, and they're coming in with instability of the ankle where the ankle constantly is giving out on them and they don't feel stable on the ankle. So I'd say that's definitely one where there's good treatment options, both conservatively and surgically, that we do generally try our conservative treatment options first. Mm-hmm. And in a small percentage of patients who do go on to surgery, there have been really great improvements in the fixation, in how we repair the ligaments on the outside of the ankle, and allowing those patients who do go through surgery to potentially be walking as soon as day 1 in a boot, and potentially getting out of the boot between weeks 4 and week 6 after surgery. And in young athletic patients, even getting them back to their sport between week 6 and week 8 from surgery. So it's come a long way. I'd say that's one of the more common injuries. Plantar fasciitis and Achilles tendonitis, I would say, are a close second.
Okay.
I think plantar fasciitis and Achilles tendonitis are something that probably 99% of the human population encounters at some point in their life. They felt either heel pain on the bottom of the heel pain on the back of the heel, whether that's walking on the beach too much, and they feel it on their beach trip, or it's after training for a marathon, where we have a lot of different conservative treatment modalities, everything from physical therapy, stretching exercises, and night splints, spanning to less invasive treatment options like PRP, platelet-rich plasma injections, or debridement of the tendon, cleaning up the scar tissue from the tendon. There's been a lot of advancements in the surgical care for these patients.
Awesome. What is your kind of take on orthotics? Do you feel that there's many people that need orthotics, or you feel like it's kind of depends on the situation?
Yeah, I do think it's patient dependent. I think that people have this idea that podiatrists overprescribe orthotics and tell every patient they could use orthotics. Mm-hmm. I don't necessarily agree that every patient needs orthotics. I think it is very patient dependent and based on your foot type. Mm-hmm. I do think that for patients who have significant deformity, whether that be flat foot deformity or severe high arch deformity, where they are starting to compensate and have other related foot pain from those issues, that getting a patient like that in a proper set of orthotics to not just act as a arch support, which is the classic way that orthotics are advertised and marketed for, but actually as a biomechanical device to help realign your rear foot with your leg, and therefore realigning with your knee, your hip, and your lower back. Because if you are someone who has a severe flat foot and you're overpronating, you can imagine that force is now going all through your lower chain into your knees. Your knees tend to be a little bit more buckled, and that makes its way towards your hips, your lower back. So patients like that who have real deformity, I do think benefit from orthotics.
Gotcha. Yeah, I mean, what you're describing kind of sounds like a bottom up approach, right? Mm-hmm. Where you change the weight bearing position of the foot, and then that transfers up the kinetic chain right up to people's hips or back. And we're a firm believer in that as well. We believe that where you're placing your weight on an everyday basis changes your posture and your position throughout the day. I'm also a believer that in terms of your anatomy, you're born with some stuff, but if your anatomy changes and all of a sudden you had a normal arch and then all of a sudden you have a very flat foot, either because of a tendon rupture or ligamentous changes, like probably need to address that,
Yeah.
And orthotic might be a great option for that.
Yeah, absolutely. I've had actually recently several patients who have had full posterior tibial tendon dysfunction where the tendon is completely torn and retracted. And patient may need surgery, realign the foot. And some of these patients do very well just with a nice custom orthotic to help realign their foot, hold the foot in the position it's in. And they've done very well with that and have avoided a reconstructive surgery.
Gotcha.
So I think it's always a great option, especially like you said, if you notice any acute change over time, I think it's important to get checked. And for those patients who are younger with the more genetic predisposition for either a severe flat foot, a severe cavus foot, or a limb length discrepancy, it is important to get checked out and evaluated, excuse me, so it could be caught before the foot continues to get worse over time. Flat foot especially, recently has been more referred to as progressive collapsing flat foot disorder, just so that we know that this is something that will get worse over time. It's not going to just stay in that position, that 10 years from now, it's going to be worse than it is from now. And 20 years from now, it's going to continue to just get worse over time.
Yeah. What is your favorite bone in the foot?
Favorite bone in the foot? I guess I'd say it's the talus.
Okay.
Yeah.
Yeah.
It's the only. It's a bone with no tendon attachment. It's a very strange looking bone.
It's like a
and
UFO.
Yeah, exactly. It plays such a crucial role in the biomechanics of your ankle and your subtalar joint that I think it's just a very unique bone in the body to be wedged between two major joints that are controlling essentially the whole weight-bearing surface of your foot.
Absolutely.
So yeah, I don't know. I've never been asked that before. 26 to choose from. So.
I'm asking the hard hitting questions.
Yeah. I have to go deep to really think about that.
I guess one of my last questions is essentially, what do you see in terms of the field of podiatry and how it's probably going to change in the next, 20 years, and where do you really see some of the advancements coming and some changes that are probably going to be taking place?
Yeah, that's a great question. I think that, podiatry and foot and ankle surgery in general is at this transition towards minimally invasive surgery. I think we're finding that if you go back to, for example, spine surgery from just recently, where they were doing more big open incisions for some of these lumbar fusions and surgeries, and now there's more targeted jigs, minimally invasive incisions, targeted patient-specific equipment. That's where foot and ankle is starting to head, with patient-specific cut guides, 3D printed ankle replacements, 3D printed cut guides for even just bunion surgery, all of which is trying to minimize our incisions for patients, which therefore decreases scar tissue, decreases pain, and improves the recovery time for these patients. So I think that we're going down this path where any surgery that can be done minimally invasive will eventually be done that way, because we're seeing, even just from the minimally invasive bunion surgeries, significantly less pain, significantly less scarring, improved patient satisfaction, and more importantly, less opioid use after surgery.
Yeah, that's great.
Which is everything as a surgeon that I'm looking for.
Yeah, I think a lot of people, there's kind of a stigma to some of those foot surgeries because some of the poor outcomes in the past. And everyone
knows someone who had a traumatic experience who tells their friends, like, never again. Never let anyone do it. And I usually have to talk those patients off a cliff and say, look, things have changed. And I'm sorry that you were treated that way, or that your friend was treated that way. But the surgeries and the technology have come a long way, where we can do this with 3 little poke holes in the skin with just a few screws and get you walking the same day after your surgery.
Yeah, that's fantastic.
Whereas in the past, you were in a cast for 6 weeks.
Yeah,
with a huge incision on the top of your foot. So we're seeing that now, that more of these surgeries, and not just bunion surgery, but even some of the ankle surgeries, ankle fusions, and ligament repairs can be done either minimally invasive or arthroscopically. Yeah,
that's really encouraging to hear that the field is changing and evolving. Caveat: I actually had back surgery, and a lot of the same kind of language be used in terms of back surgery, like, oh, never get a back surgery, you'll never be the same, blah blah. And I had a microdiscectomy where they actually do like a small laminectomy, but it's essentially minimally invasive as well. And outcomes in terms of the actual research are like 97% effectiveness. So I hope to see in terms of the future. I'm sure that there's research being done now in terms of the minimally invasive surgeries.
Absolutely, yeah, tons of research around it, so that mainly to help prove not just to patients but to other foot and ankle surgeons that, hey, you don't have to be hesitant. This is real. I mean, patients are happy, and we're not just saying that. Don't just believe what we're saying, but look at the literature that's out there. We're seeing at least similar or better outcomes with, again, less pain, less scarring, which that's what it really takes to change a profession, to change the podiatrists and orthopedists out there to go down this path of learning minimally invasive surgery. Usually takes literature and proof to say, this isn't just a trend.
Yes.
This is the way the profession is going. So either change with it or get left behind.
Yeah, absolutely. Do you have any questions for me as a podiatrist to a physical therapist. I mean, we're just kind of meeting each other, but
sure.
Is there anything that you would like to know?
Yeah, I guess, from my end, going back to our example before, when I'm seeing a patient, whether that be for a post-op appointment or a patient we're sending physical therapy to hopefully prevent surgery, is there any specific detail you're looking for from us other than just a prescription with a diagnosis? Is there anything you're usually looking for, or are you just getting that information mostly from the patient when they come?
I mean, unfortunately, yes. Most of the time it's through the patients, and they're not necessarily the most reliable witnesses. But if it's post-op, I am looking for a post-op protocol. If the surgeon has a specific methodology or procedure that they want to be followed, I find that more detail there is more helpful than less detail. I'm also looking to see, like, what kind of surgeon is this? Is this a surgeon that is very conservative in their post rehab protocol, or are they a little bit more aggressive in terms of their timelines or what they're allowing the patients to do? That also gives me a little bit insight of, like, how major the surgery was, or what other risk factors there might be. Like, for example, there's an ACL patient, and he, kind of rarely do you see someone just getting an ACL repair. There's usually like a medial meniscus in there, or an LCL or MCL kind of stacked in there as well. And you see that reflected in their post-surgical protocol. And I had a patient who just had their ACL, and their post-surgical protocol was like very different from some of these other post-surgical protocols. And that gives me a little bit of understanding of, like, what the surgeon's goals are and how they want their rehab conducted, right? If they want me to hold their hand, they might kind of indicate that in the post-surgical procedures. But if they want me to really throw the gauntlet, that's this person, they want to get back to MMA and they want to get back to the football field, maybe there's a different sort of approach that we're going to take.
Yeah.
Also, for me as a physical therapist, I value communication greatly with the surgeon. And if the surgeon gives me the ability to be able to communicate with them, either through email or a text message or a phone call, I think that's worth its weight in gold. Like, I had a patient, another ACL, who was presenting with signs of a DVT, and immediately I had the surgeon's phone number, like his cell phone number.
Yeah. And
I texted him, and he got me going through, the ER or whatever. We had them go into the office. They got a Doppler, and then they actually had to go to the ER as well. But it was it's good to have that open communication, because then I could, if there's even a question of like what I should be doing here, and I would, of course, like the doctor's feedback about like what their opinion is and how we should proceed. And if there was something that I didn't know about in terms of the surgery or whatever condition that the patient might be having that maybe I missed, or I'm not too sure about.
Yep.
Yeah.
Yeah, I totally agree with you. I think I almost, with all the therapists I work with, I give out my cell number for that reason specifically. I had a patient recently who had a wound issue, and the therapist saw right away, had, got the patient in that day, got it taken care of, and he healed great. But I was really appreciative of the therapist calling me, because I think sometimes patients don't know, and they let it sit. And by the time they come back to see me, I don't see them necessarily 2 to 3 times a week like the therapist. The therapist knows the patient sometimes better than I do when they're seeing them that often. So when they see that something's not right, or there's a question, having the therapist giving me a call, or vice versa, if the patient's with me and I'm seeing they're still stiff, they're not doing as much as I want them to do, and I could call and just say, hey, I need you to, let's get more aggressive.
Yeah.
Okay.
Yeah.
So I think that open line of communication is crucial for these patients. And it's hard, because when you don't have that, then you're just going through either the patient, or you're going through just a prescription pad, and it's just, it doesn't benefit the patient.
Yeah. I mean, I can't tell you how many times where, according to the protocol, we're doing really, really well, or we're on timeline, but I feel like we could do so much more even though the protocol says not to. And then if I were to be able to communicate with the surgeon, like, hey, like Bill's doing really well right now. Like his range of motion's great. His stability is fantastic. He's his lunge looks really, really good. Can we start some dynamic activities? And the surgeon would, if I was able to speak with them, would probably be like, yeah, go for it. Let's push the envelope. But I can't, right? Because it's against procedure, right? So just having that open line of communication could even benefit the timeline and the outcomes for the patient as well, right?
Definitely, because I think at the end of the day, medicine comes down to the more that we could get patient-specific treatment and individualized care for these patients, the better. And that usually takes an open line of communication between the internist, the therapist, the PA, and that's what's hard about medicine these days is just communication in general between all the specialties.
Everyone's disjointed and covering their own butt.
Yeah, that's pretty much what it's come down to. Or they're in different medical systems, in different practices or hospital systems, and it's just hard to get the right information for that patient.
Or there's no time.
Or there's no time, right? By the time you spend 15 minutes on the phone waiting to get the MRI report for that patient, you have now 3 patients waiting to see you. Exactly. So it's become difficult for that. So I think, like I said, I usually just give out my cell so that it's right then and there, just get it done.
Yeah, I mean we're a low volume clinic, right? So we treat 1 patient an hour. In terms of being able to provide that individualized care. Not only can we communicate with the patient, but it allows us and gives us time to communicate with the doctors as well. And in terms of developing programs that are very individualized, like I've worked in places where I treated 4 patients an hour. I've worked in places where the volume was more important than anything else. And I think that's the big difference between working in a place where you can really take the time and develop a program that's appropriate for this individual and walk them through it. And it's not, somebody else doing the grunt work, right? My hands are on the patient. I'm the one communicating with the doctor. I'm the one developing their program, and being able to control all those things, it's more than likely that they're going to have a good outcome.
Yeah, I think that's what's being lost, unfortunately, with some of these large hospital systems, and that you don't have the time. The providers don't have the time to do that for their patients. They're so overloaded with patients that you can't pick up the phone and call the therapist and chat for 10 minutes about that patient. It's just that there's not enough time in the day to do that. Where, like you said, we're in a similar private practice setting where we have the autonomy to control how long we spend with a patient and how many patients we see, so that we could make sure that these patients are getting the care and time that they deserve.
Yeah, absolutely. Well, I appreciate you taking the time and care to come and visit us on the podcast. It was a pleasure speaking with you.
Absolutely. Thanks for having me.
Yeah,
really appreciate it.
I hope to work with you in the future. And is there anything else you would like to say or mention?
I think that's pretty much it. I think that you and I have similar mindsets in how we approach patient care, which is, I think, important. So what it comes down to is just communication amongst a medical team for a patient.
Absolutely. Thank you so much for your time. And we'll see you guys next time.
Thanks so much for tuning into today's episode. It really does mean a lot to us. And don't forget to like, share, subscribe, or comment if you got at least 1 or 2 helpful insights or takeaways to help you get to your next level.